First degree atrioventricular block is manifested in the ECG as prolongation of the PR interval. Normal PR interval ranges from 120 to 200 milliseconds. First degree AV block is a very common finding and if isolated does not carry additional prognostic significance. But if it is associated with other conduction abnormalities like bundle branch blocks, it gives added significance, indicating a more severe conduction system disease. It can be seen in acute rheumatic fever. ECG showing sinus bradycardia with first degree AV block. RR interval is 1280 milliseconds corresponding to a heart rate of 47 per minute and PR interval is 320 milliseconds. Second degree AV blocks can be either Mobitz type 1 or type 2. Type 1 is also known as Wengi-Back phenomenon. Mobitz type 2 block is usually associated with intraventricular conduction defects like right bundle branch block, left bundle branch block, hemi blocks, or a combination of these. Typical features of Wengi-Back phenomenon are 1. Progressive prolongation of PR interval followed by a dropped QRS. 2. Progressive shortening of RR intervals. 3. This is because the increments in PR interval are decremental. 4. Pause due to dropped QRS is less than twice the previous RR interval. Mobitz type 1 block is usually more benign and due to AV nodal pathology. Progression to complete heart block is less common. Even if it progresses to complete heart block, the escape rhythm is of narrow QRS and has a good rate. Second degree AV block associated with inferior wall infarction is Mobitz type 1. Conduction ratio in second degree AV block is mentioned as the ratio between the number of P waves in the Wengi-Back cycle and the number of QRS complexes. For example, if 3 P waves are conducted and the fourth one is blocked, it is called 4 to 3 Wengi-Back block. In Wengi-Back type of block, the conduction ratio is always in the form of x plus 1 is to x. That is, only one P wave is non-conducted in any cycle. Highest grade of type 1 AV block possible is 2:1 AV block, in which the ventricular rate will be half that of the atrial rate. That means 50% of the P waves will not be conducted. In Mobitz type 2 second degree AV block, there is no progressive prolongation of PR interval. Instead, there is an abrupt droppage of a QRS. Hence, the pause is exactly twice the previous RR interval and there is no variation in RR intervals except for the pause. There may be no prolongation of baseline PR interval. Mobitz type 2 block usually originates below the His bundle and as mentioned earlier is associated with other intraventricular conduction defects. Mobitz type 2 block carries a more sinister prognosis as the escape rhythm which occurs if it progresses to complete heart block is of wide QRS, lower rate and unstable. Location of the block is below the bundle of His or infrahisian. In this ECG, there are 2 P waves for every QRS complex with atrial rate double that of ventricular rate, denoting 2:1 AV conduction or 2:1 AV block. In addition, there are features of left bundle branch block suggesting infrahisian block. Left bundle branch block is indicated by wide slurred QS complex in lead V1 and wide slurred R waves in lateral leads. Typical M pattern is visible in V5. T waves are concordant in lateral leads, that is T waves in same direction as QRS. This indicates a primary T wave abnormality. T should have been opposite to QRS in left bundle branch block. When 2 or more consecutive P waves are non-conducted, it is termed advanced AV block. Advanced AV block is midway between usual second degree AV block and complete AV block. ECG showing advanced AV block with RBBB. PP interval is 480 milliseconds corresponding to an atrial rate of 125 per minute. PR interval is relatively fixed at 440 milliseconds for most of the conducted beats, though the conduction ratio varies between 3:1 and 2:1. That is 2 P waves visible between second and third and 5th and 6th QRS complexes in the rhythm strip marked in red color. Some of the P waves are overlapping with QRS complexes. Two of them, which are clearly visible, have been marked in green color. Others are fully within QRS, so that their presence should be inferred based on the regular PP interval. QRS complex is wide with RS R prime S prime pattern in V1 and slurred S waves in lateral leads indicating right bundle branch block. Q waves and T inversions are noted in inferior leads. In the setting of inferior wall infarction, as evidenced by Q and T inversion in inferior leads, though suprahiscent type of block, that is type 1 block, is more likely, presence of RBBB would indicate a type 2 AV block. Intracardiac electrophysiology study is needed in this case to delineate the exact mechanism of block. In complete AV block, there is no relation between atrial and ventricular rhythms and they are completely dissociated. The four classical ECG criteria for diagnosis of complete AV block are 1. Regular PP interval, 2. Regular RR interval, 3. PP interval shorter than RR interval, that is atrial rate more than ventricular rate, 4. Totally varying PR interval indicating AV dissociation. Though the PP intervals and RR intervals are usually regular, there could be some variations occasionally. If there is an occasional conducted beat, the ventricular rhythm can show irregularity. Junctional focus can have slight variation in rate due to autonomic influence. Atrial rates can show two types of sinus arrhythmia. In respiratory sinus arrhythmia, PP interval shortens during inspiration as the rate increases and lengthens during expiration as the rate decreases. In ventriculophasic sinus arrhythmia, a PP interval enclosing a QRS complex will be shorter. This is thought to be due to the mechanical effect of ventricular systole causing enhanced pulsation of the sinus node artery penetrating the sinus node. It has been shown that the ventriculophasic response can be enhanced by deep inspiration, like in case of sinus arrhythmia. The location of block in complete AV block can be either above, that is suprahischian, or below the bundle of His, that is infrahischian. In suprahischian block, the QRS complex is narrow and has a relatively higher rate as it arises from the lower part of the AV junction. In infrahischian block, the subsidiary focus is from the ventricle and has a lower rate with wide QRS complex. The subsidiary rhythm in suprahischian AV block is more stable than that in infrahischian block. Hence, there is a higher chance for Stokes-Adam attacks with infrahischian block. In the setting of acute myocardial infarction, suprahischian block is usually noted with inferior wall infarction and infrahischian block is associated with anterior wall infarction. The latter is often associated with significant left ventricular dysfunction and poorer prognosis because of the large area of myocardial damage involved. Suprahischian complete heart block in inferior wall infarction is usually reversible. Infrahischian complete heart block in the setting of anterior wall infarction is more likely to be permanent. Even if there is partial recovery, very often bundle branch block or fascicular blocks remain. References on ventriculophasic sinus arrhythmia.